Other business.
Mr. President, this is actually a responsibility of yours as president of the board. We're asking for a standing committee regarding these requests so that we can take them in a more expeditious manner before the Board of Health. And that sometimes there are reasons to try to respond to the request for research in a more expeditious way instead of having to wait for our quarterly meeting. And we'd like to create a kind of a cadre of experts on the board. We've worked with Catherine Tapp, of course, and Catherine has agreed to chair this committee for the standing committee going forward. In your book, we're asking for Dr. Fincher, Mr. Harper, Dr. Hoy, Dr. Foster, in addition to Catherine Tapp, be appointed as a standing committee to consider future requests for access to this cancer registry information.
Very good. You gave the responsibility to me, so do I present it to them and ask for their approval?
Yeah, we can go ahead and do that as well. That be put on the form of a motion on the table. But since it is a standing committee, I think our bylaws technically would give you the authority to do so, but we can, it's certainly open in case, I hope we've contacted everybody that we've asked on the standing committee. And I hope nobody opposes or would not wish to serve, but if they do, of course, now we can take those numbers off.
Well, I guess one question to ask, is there any amongst us that would like to join this committee? And is there anybody that objects to their name being on this committee? Dr. Fincher?
I just found out about it. Thanks, Rick.
Oh, sorry.
We didn't want to give you any time.
Time to think about it, yeah.
All right, so is there a motion to accept this committee as has been presented?
I move.
Second.
Dr. Zini seconds. Any further discussion? All in favor, say aye.
Aye.
Are there any opposed? Thank you,
Study.
Mr. Hogan. Next, appointment of Phillips County Health Officer.
Again, I'm kind of standing in for Dr. Bates on this one, Mr. President, members of the board. This is a request by our our county judge in Phillips County and also by our local health administrator in Phillips County to appoint Dr. L.J. Bell of Helena as our county health officer for Phillips County, Arkansas. I believe he's agreed to serve, and we have the requisite statutory requirements have been met, including the letters of requests that are included in your packet. We'd ask for a motion to appoint Dr. L.J. Bell of Helena as the Phillips County Health Officer.
I so move.
Is there a second? Second. Any further discussion? All in favor, say aye.
Aye.
Are there any opposed?
Thank you, Mr. President.
Thank you very much. Next, a licensed lay midwife statistical report. David Grimes.
Mr. Chairman, members of the board, I have the honor of presenting these statistics for perinatal outcomes of home deliveries of licensed lay midwives in Arkansas. You can see calendar year 2014. We've tried to break these statistics out in a more understandable fashion. Prior to 1998, we did not track antepartum referrals, so you can see in your report we have no data for that part of the information. But starting with 1998, we do track antepartum referrals as well as the total number of cases. So for calendar year 2014, there were 245 home births by licensed lay midwives. of which there was one perinatal death. There were 32 interpartum transports. In other words, during labor, the patient had to be transported, and 5 infants were transported after delivery at home. There were 106 antepartum referrals, and there were a total number of cases of 353. Are there any questions?
Yeah, I have one. How would the perinatal deaths stack up with respect to the births? Whatever the ratio would be, as opposed to deliveries in hospitals, say by nurse midwives? That's not, I didn't say that very well, but I hope you understand the question. Is this pretty consistent?
George, can you use your microphone as well?
I'm sorry. I was just inquiring as to, I noticed that, for instance, between 86 and 2014, there were 45 perinatal deaths with 5,000 deliveries, births. Is that consistent with the number of deaths you would expect from hospital nurses?
Typically, the number of perinatal deaths in a home delivery are going to be higher because they do not have the immediate availability of emergency cesarean section for ruptured uterus, prolapsed cord, those kinds of complications. So the statistics are a little bit difficult to determine because of the reporting inconsistencies across the state and across the nation. In states like Oregon that has specifically looked at out-of-hospital births, they typically find that home births probably have anywhere from 3 to 10 times the perinatal deaths that a hospital equivalent birth would have. Any other questions?
Thank you very much. I think this is informational only.
Correct.
Next, an update on the rules and regulations pertaining to body armor.
Thank Katie.
Yes. Oh, Mr. Jones is at the podium.
Okay, thank you.
You're welcome.
You can see I'm not Peggy Walker, I am Tom Count. Thank you, Mr. Chairman and Board. I would first off, you have a handout here that we need to look at. This first paragraph, we need to make some adjustments with. Yes, I am in this committee, and also Mr. George Harper is in this committee. Dr. Braden, you are, and Peggy Walker. And we are being encouraged from several directions to add Dr. Mason to the Arkansas Department of Health. I know that Dr. Mason has been in on several of the meetings concerning the body art regulation and especially in the scarification procedure. Elizabeth Pittman is to give us our next set of regulations that has made it through some review, and I think she's going to be giving that to us this next week. I would like you to read through some of this information in a preliminary report here. I went into an establishment over in the Bryant area, and I'm not unfamiliar about being in one of those places because I at one time inspected 40% of the body art establishments in the state of Arkansas about 17 years ago. I came out of the establishment with a lot of questions answered, but I will be very honest with you, I had more questions in my mind after that than I walked in. I think the committee will do a good job as good as we can on gathering information, especially my concern is in aftercare. And we will bring that back to the board probably the next quarter.
Thank you very much.
Thank you, Mr. Jones. As Rick wanted me to step in and kind of give you an update on where we were with the actual roles. As you may or may not know, Becky Benz, who was in charge of the program, has retired. So we've had to kind of, that's sort of why they've been delayed. And we do have a current draft from the program that people who have taken over that program from her. And I will be parsing through it and trying to see what we need to do to move it forward. So as Mr. Jones said, hopefully we will be back in July with a new set of roles for you guys to approve and move forward. We had several public comments back in December, and we've had to make substantial changes to the set that was approved in October, so we will have to come back for a new approval.
Next, an update on rapid sequence intubation. Dr. Greg Brown.
Yes, sir, Mr. President, good morning, and members of the board, good morning. Again, I just provide you with some oversight and some information on practice of rapid sequence intubation. The reason we brought this up is there was a recent event that involved a child that was under the age of 8 years old that they were unable to get an airway on, and currently rapid sequence intubation is not allowed in children under 8, based upon a recommendation of the board back in 2007. So it was brought to Dr. Bledsoe's attention, the Surgeon General, which eventually came to Dr. Smith, and then Dr. Smith funneled it back down to myself, to kind of maybe give the board an update on where we are with this procedure kind of historically. And then at some point, maybe in the future, hopefully we can address the issue for children under 8 years old in providing this particular procedure. Just as a matter of historical perspective, back in 2007, really back in 2007, some of the medical services, and Dr. Ledovich is familiar with this well, and more particularly MedFlag at the time, rapid sequence intubation was not a standard scope of practice for EMS personnel. It was considered an expanded scope. But it was important enough that several aeromedical committees in the community came together and petitioned the board back in 2007 to allow this expanded scope to be practiced not only by our flight nurses but also by our flight medics. And it was approved back in 2007 with the caveat of an 8-year-old restriction. And there was some discussion around that point. That wasn't the proposal by the aeromedical community, but it was the recommendation by the board that in order for us to practice RSI, there would be this 8-year-old restriction. And so we practiced from 2007 up till recently with that restriction in place. Over the last few years, there have been some events involving children under 8 where there have been some issues in obtaining an airway in the field. And some of the physicians, this was brought to us by an emergency physician in an ER in the state who encountered this particular event and really raised the question, why aren't we allowing rapid sequence intubation in all ages? And so went back, and if you remember back in 2014, in the early part of last year, we presented the new rules and regulations for emergency medical personnel. And in that rules and regulations, RSI is now considered a routine scope of practice for EMS personnel where, 5 or 10 years ago it was not. And so today, and within the rule, there is no age restriction per se within the rules and regulations. The rules and regulations that were passed by the board basically says that RSI is a standard scope of practice for the paramedic, and there's no age restriction. However, we agreed with the board when we put the rule in place that we would continue with the approval process. And so just to give you a quick update, when a service contacts the section and says, we would like to do rapid sequence intubation as a part of our standard scope, we say that's great, but we go through a lengthy process to make sure that they are prepared to do that, even though it is a standard practice. We meet with their medical director. We make sure that all their paramedics go back through the operating room under supervision of either an anesthesiologist or a nurse anesthetist to practice a set number of skills to make sure they're proficient. They are reviewed by their medical director, and the medical director signs off that they are able to perform that particular skill under their license. We get those, we review those, we make sure there's continuing education, we make sure that they're actually doing the things that they said they were going to do. We also allow them to present to us an evidence-based rapid sequence intubation protocol that is reviewed to make sure that it meets some of the national standards that are out there, especially as far as medications go. Once all those things are reviewed, we sit down with the medical director, the training officer, the owner of the ambulance service, and whomever else that they feel is important. Then we go over to ensure that they understand exactly what they're supposed to do. Now, this is uncommon. Most other states don't go through this process, but we feel it's important just to make sure that everybody is on the same page and practicing uniformly across the state. However, with that is that restriction of 8-year-olds is still in place. We did not take that out, even though the new rules would allow us to. When the board ruled and gave us the permission to proceed back in '07, with that age restriction, we kept that in place because we didn't want to just ignore what the board had provided for us in '07 just because the new rules say that there is no age restriction. So that's kind of where we're at. And so I think the conversation going to be going forward is, at some point we are going to provide maybe some research. Now, we don't necessarily have data on pediatric intubations as far as RSI goes in the state because we don't do them, so we don't know how many there would be. But we can look across at other states, we can look across some of the studies that are done, and some of the ones that I've looked at are very promising in the field of pre-hospital EMS with rapid sequence intubation in children. You know, with airway compromise in children being pretty much the #1 cause of fatalities in small children. This is a very important procedure. And so while we do have the age restrictions, the other states don't usually have that restriction. Now, there are some states that don't allow RSI at all, so we'll be clear with that. I don't want to make it sound like we're the only state not doing it. That would not be a good assessment. But I think that where we are today with the training that we've provided with our providers, with it being a national scope of practice, with it being the oversight that we provide over the services and the in-depth application process and review of what they do, I think that we are in a position now to readdress the age restriction that was put on back in '07, because I think that our providers are ready, willing, and able to perform this skill with high accuracy and efficiency when it comes to these children. So I'm happy to entertain any questions, but I just wanted to give you kind of an idea of where we are since it was brought to our attention. And I was asked to kind of give just a brief summary of this process and this procedure, and maybe where we go from here in the next steps. Any questions? Yes or no?
Is there a concern that, as it stands now, that if we have a child under the age of 8, we could lose that child unnecessarily, as long as we continue to have this rule in place?
I mean, I think it's always a possibility. I mean, within the I use the word arsenal, if you will, within the tools that the paramedic has. I mean, they have the ability to use secondary rescue airways. Sometimes those aren't effective depending on certain situations and certain patients, but I think that having this tool available to them in those extreme, really extraordinary conditions when this procedure would need to be done, having the ability to allow our EMS personnel to do this procedure, I think certainly could save lives, there's no doubt.
I'm a little confused.
Yes, sir.
You said the new rules eliminate the age restriction.
It does not address the age restriction, correct? That is correct.
So the restriction is a verbal, or is it written in your rules?
The restriction was in '07 to our EMS community that yes, we will allow the RSI procedure with the understanding that you cannot perform that under the children under the age of 8. And so that's been a standing restriction.
But that's not written.
That is not, it's all, no, it wasn't written. It was a,
Why?
that's correct, by the board back to us. I mean, it was written obviously in minutes, but outside of that, it wasn't written in any other form of statute or rule.
go back to his question then, if it's not a written rule and it's felt that they need to do the rapid sequence on 8 or under,
Yes, sir.
is there liability if they don't?
That's a good question. And I think with it being a standard scope of practice now for the EMS providers.
There's a question.
Richmond, if you can use the,
Details.
Sorry.
So, at any rate, the question I have asked is if there's no written rule on not using rapid sequential intubation on 8 years and under, it's just an implied restriction. What's the liability if it's needed and it's not done?
I mean, again, that's a great question. I think the age restriction, as it currently exists today, is being done out of the respect of the board for the decision that they made back in 2007. Having not gone back and said, we really think that we can get around that restriction, or we don't hold that community to the restriction anymore. But really, out of the respect of the board, we've continued that through the application process, even though within the rule it does not carve out an age exception. So that's a great question. And I don't know legally what the answer would be. Yes, sir.
is it, the implicit question, I guess, is that still the will of this board?
I think that would be the question.
Barbara, what do you?
I'm sorry, what was the will of the board?
The reason why they're not doing the rapid sequence innovation in those children under 8 is because of what the board had recommended back in 2007. So implicit in that is the question, is that restriction still, our recommendation still the will of this board?
Well, I think you probably have to ask the board to see, there's still some reservations that people have about rapid sequence intubation overall. And that is that once you give one of these drugs to someone to make them stop breathing, some of the drugs you can't just say, well, we'll wait 10 minutes and then we'll go back and have at it. They're paralyzed, there's nothing that they can do other than arrest you their way. And that was really bringing me to my question is the oversight the board has, and Greg mentioned that. So Greg, my question to you is, in the last 12 months, how many rapid sequence intubations have been attempted? And of those, how many have been successful? And how many have not been successful, and what's been the outcome?
And that's a great question, and I don't have that. I mean, we've got the data. I did not bring it today. I wasn't prepared to bring that today to present a report for a vote. But we do collect those. As far as outcomes, are we talking just general, was it successful or not outcome? I mean, we don't have the ability to look at long-term outcomes for sure.
Would it be reasonable for us to have a committee of this board look at those data and evaluate this question? I would hate for the Board of Health to be tying the hands, of any practitioners, based on a decision that we made, years ago, without having a chance to look at it again, fresh, looking at our data, looking at the emerging science. Rick, what would be required for us to have a committee? Certainly, the president could form that committee. Just for historical purposes, to try to went back and looked at the minutes in 2007 and years in there. This discussion was informed by Dr. Jane Sneed, who was a pediatrician on the Board of Health at the time. Dr. Sneed at that time was the one that recommended that there be an 8-year-old restriction be placed into practice based on her knowledge, experience, and expertise as a pediatric physician. So we haven't revisited that. I think by order of the board over the years, rapid sequence innovation is something that originally came back annually for the board to consider the data and the report from the staff on. In 2011, we changed that, I believe, to every other year or it was changed recently. So there have been some changes. I think it's more than appropriate to form a committee or subcommittee of the Board of Health to further study it and bring back a report in July to inform the process.
It would be for you to authorize that, but my request would be that if we were to do that, that we would request Marv and also Greg Bledsoe, who's now a member of this board, to be on that, along with any others who would like to, or whoever you would want to.
So it just occurs to me, why don't we defer that, and I'll ask any of you amongst us to come to me after the meeting, and I'll put together a committee, if that's okay. Is that appropriate? Dr. Fisher?
I would like to make a comment, particularly for the non-physicians on the board, for rapid sequence. It sounds like, we're withholding treatment from young children at their expense. Rapid sequence intubation is no joke. I mean, once you paralyze the patient, which is involved in this, as Marvin indicated, if they're not successfully intubated, they die. Intubating the trachea in the field is not as easy as it is in the emergency room or the hospital. I personally attempted in-field intubations without success. It is not the same thing. So I'm not sure what the reasoning behind the age limitation was at the time, but I do understand the concern about paramedics doing rapid sequence intubations in the first place, and period. I'm an emergency medical system medical director, and I know that one of the issues we have is medics making the proper decision as to when to employ these advanced techniques, and that can be an issue. If a patient is paralyzed in a situation where they didn't need to be, this could lead to the death of the patient, as opposed to they might have survived if not. So it's not as simple as we're going to withhold this treatment from children under 8 and we don't have any rationale for it. But I do have personal questions about what the rationale for the age discrimination is. And I think it's a good idea to appoint a committee to look into that further and decide if we want to continue to have the same rules or to revise those. And that would be my comment.
And to your comment, you're exactly right. It is certainly not to be downplayed as a minor skill. It is a very important life-saving skill when it is needed. And without proper and really integrated medical direction, the service does not need to be doing. And that's why we certainly allow medical direction to be at the top of it. Yes, sir.
Just out of curiosity, do you know why the patient could not be intubated?
I don't know, Marvin. I really don't. All I know is that it was, when the event played out, the emergency room physician, who's also an EMS medical director, asked the flight crew, why didn't you RSI this child? And the response was, we can't do them under 8. And that set off the cascade of phone calls and emails at that point. So there wasn't a complaint, there wasn't an investigation process, so I don't know the details behind it.
But they did attempt to intubate.
Yes, sir.
Just unsuccessful.
My understanding, and I think that the consideration at that time was either to do a crike on the child in the field or withhold and let them RSI the child in the ER. And so I'm not sure exactly all the details to that, but I think the question was, if we could have RSI'd, it may have, we really didn't want to crike this child, and we think we could have got it under the conditions. I think it was a traumatic head injury, and there was some other associated issues with that. So, aside from all the details, I'm not sure, but this isn't the first time that I've heard this over the years, and so that I know that it exists. I know that this particular scenario has played out more than once. But again, to your comments, it's a very
critical life-saving skill if done appropriately, and the right rationale is used, certainly correct. And I'll be happy to provide the board with any information, and we can certainly go back and provide the data.
I think if we have a committee that can look at the data, I mean, that's one of the critical issues. How are we doing with rapid sequence intubation? If 50% of the patients are dying, then that's a real problem. If, however, you're losing 1 or 2%, well, that's certainly,
In the last report I think we gave to the board, if I'm not mistaken, the success rate for rapid sequence intubation in the field was at 96%. So we were 96% successful with RSI by the third attempt. So obviously, going back to what you said, sometimes the first or second attempt is not successful. But I believe by the third attempt, we had 96% success rate, which is probably, I mean, that's exceptional when you look at the patients that we were dealing with when we have to perform this skill. The numbers aren't high. Again, this is a low volume, high critical skill where a lot of education is involved. So having a 96% or so success rate on those is exceptional for our emergency personnel in the field.
Thank you.
You're welcome. Thank you, sir.
Next, an update on ADH reports from the 90th General Assembly regarding legislation.